All right. Now let's talk about a really great drug if you got somebody intubated. This is the drug right here, and I'm talking about vecuronium. Long-acting paralytic. We like vecuronium, especially if somebody's intubated. We want them to remain intubated, and again, if they can't move, they can't pull their tube out. So again, we're going to talk about the difference between this and succinylcholine. The biggest thing, again, it's also called norcuron, but it is it's a derivative of pancuronium or pavulon, which too is a long-acting paralytic. And this is actually kind of dose-dependent. The more that you give, the longer the paralysis is going to last. So again, it is a sympathomimetic, but it is a non-depolarizing agent. Non-depolarizing, longer word, longer paralysis. Good way to remember it, okay? Now, we usually do not use this for the initial RSI. There are some docs that will use it. Understand that they might use it, but in the pre-hospital setting, we usually use the short term, we use a succinylcholine, and then once we have them intubated, we use the vecuronium, rocuronium to maintain the paralysis, but again, we do the initial one with succinylcholine. If you use VEC as your initial, and you cannot get an airway established, you have bought that airway for 30 to 45 minutes. Long and short, you don't want to use VEC as your initial paralytic unless your doctor very specifically says to do so. And there might be some times where that is the case. Most of the time it is not. And again, it competes for acetylcholine in the receptor sites, and it produces long-term skeletal muscle paralysis. So again, it usually takes about 3 to 5 minutes to work, and then it's going to last for about 25 to 30 minutes. And I will tell you that this is probably a little bit longer depending on how much that you actually give. So again, we use it for prolonged paralysis for the intubated patient. Once you have them tubed, this is the drug you want to go to. And I should not only say, not only do you have them intubated, but we have confirmed that that tube is in the right place. All right. So again, standard side effects that you would have with this, it does increase intracranial pressure, but not near as bad as the succinylcholine does. But again, it can cause a transient hypotension, PVCs, tachycardia, and these are usually due to the person's not breathing or not being ventilated correctly. Again, a little bit of nausea, vomiting. Remember, it paralyzes everything, including the sphincters, so you could get a release of this. And it does also, not as bad as succinylcholine, but it does increase intraocular pressure. So again, guys, we don't, penetrating eye injuries, we usually stay away from it. Any type, if they have known malignant hyperthermia, I know I kind of hammered this out when we were talking about succinylcholine, but the same thing goes with VEC. It's not as bad, but it still does cause a shift. The other thing is we don't use this in newborns. Absolutely do. The really young babies, we don't want to use the vecuronium. There's other ways that we would keep them sedated. Again, remember, the narrow angle glaucomas, hepatic or renal failure. We have some problems getting rid of that. That's the reason why we usually don't go to the vecuronium on those. We usually just maintain sedation on those patients. Your Valium, your Verseds, your Ativan, Propofols, those type of drugs. Again, as far as drug interactions, again, theophylline's a depose-dependent. It can blockade, actually. So if they're like on an aminophylline regimen, we talked about it in the succinylcholine, but your asthmatic patients as well, if they're on that type of drug, understand that we're going to have to probably give some more VEC in order to keep them down. Make sure that you discuss this with the patient. You're going to explain that, hey, I'm going to use a short-term paralytic, then followed by a long-term paralytic. Again, and then one of the biggest things that, remember that just like with succinylcholine, this has zero effect on sedation or pain management. If you're seeing a patient tearing up on VEC, you probably need to sedate them some more, give them some pain medicine, because we want them really to forget this. One of the biggest problems, as a matter of fact, when you see a tachycardic on these patients, most of the time the sedation is wearing off, but if they have a long-term paralytic on board, they're going to be aware of what's going on. So you might have a patient that has a heart rate of 60 or 70, all of a sudden shoot up to 110, 120. You've probably lost your sedation. So make sure that we re-sedate these patients. Again, you must make sure that you have a way to ventilate these patients. Keep a mask close by. Make sure, and again, it will not stop seizure activity. So they are still going to have the neurons firing in the brain, even though they are quote unquote paralyzed. All right. So again, watch their pulse rate, cardiac output. Again, if you see that heart rate shooting up, start checking your patient, especially check the sedation levels. Make sure you do that. Again, it usually comes in a 10 milligram vial, and the standard dose is 0.08 to 0.1. I will tell you that 0.1 is most oftentimes used on these patients. And we usually give it slow IV to prevent any type of hypotension. Again, so a standard dose for the 100 kilo patient is usually 10 milligrams. That's the usual. 5 to 7 is normal for the 70 kilogram male. 7's your usual. And again, guys, pediatrics may require higher doses because, again, they don't have the receptor sites like the adults do. Now, again, we give this drug IV or IO. We don't give it any other way. And it does cross the placental barrier, so we got to be careful with it with the kids. With the pregnant females. With that being said, that's what I got on VEC. Again, is kind of a staple rule. We don't give VEC until we have the tube in place, and we know that we have the tube in place. And I usually resedate the patient before I give them the long-term paralytic. All right, guys, hope that helps, and we'll see you next time.